Hi, I'm Dr. Robert Glatter, Medical Advisor for Medscape Emergency Medicine. Joining me today to discuss a novel approach to reimbursement for emergency medical services is Dr. Jesse Pines, Chief of Clinical Innovation, U.S. Acute Care Solutions, and Professor of Emergency Medicine at George Washington University and Drexel University, and an expert in health policy. Also joining me is Dr. Steve Schenkel, Professor of Emergency Medicine at the University of Maryland School of Medicine, also Medical Director of the Emergency Department at Mercy Medical Center in Baltimore, and an expert as well in health policy. I want to welcome both of you gentlemen to this discussion.
Yeah, thanks for having us.
Jesse, your article, along with Dr. Lubitz in the recent ACEP Now, really resonated because, obviously in emergency medicine, we're trying to, reduce costs where we can, but obviously provide high quality care. And the impact of this is felt everywhere. And what we do at the beginning in the emergency department matters. And I think, the fact that Maryland has had the ability to craft such advanced APMs and APMs in general is interesting. This dates back to the 70s, I believe, according to your article that you discussed. So I guess I'll start off with really to just educate our audience. What is an APM? And Jesse, I'll let you begin. And Steve, please feel free to jump in.
Basically, what an APM is an alternative payment model. The operational definition is one that is not sort of traditional fee for service, which tends to be transactional, where a patient and a clinician get together and there's a bill, and there's really no change in that bill based on the quality of care or the value delivered. That's sort of traditional fee for service. Alternative payment models sort of do it in a different way, and it can be done by either paying a bonus to the clinician for providing better quality service, or taking money away from that clinician for providing lower quality service through some sort of gain sharing model where there may be some savings from doing things a different way, and that would be shared. And then really the highest level of APMs is sort of global capitation, where there's a fixed amount of money to take care of a population.
So ultimately, Jesse, I'd like you to describe the mechanics of this model, how it operates, how it works, how calculations were made, and to explain how you arrive at the monies that emergency physician groups and hospitals can retain, and obviously the behaviors that they can engage in practice to make this APM work.
There's a variation in physicians' decisions to admit patients to the hospital. Work that I had done years ago demonstrated that there was 2 to 3-fold variation within hospitals and across hospitals in terms of this decision that emergency physicians make. And that was really sort of the beginning of the basis for this, is can we start leveraging some of that variation and getting clinicians to put in evidence-based protocols, and then providing some shared savings back to the clinician for actually appropriately reducing admissions where the patient may not need to be in the hospital. So basically the architecture of this is it focuses on Medicare fee-for-service patients only, because that's the group that is regulated by the group at HSCRC in Maryland. And it hones down to diagnoses where there's variation in the decision to admit. So that includes diagnoses like chest pain, pneumonia, syncope, takes out things like severe trauma, heart attacks, strokes. It also takes out things like ankle sprains and abrasions, where there's just not going to be a lot of variation. And it basically takes the total cost of those visits for a baseline year. And in the case of this program, it's 2019. And that cost goes out to 14 days. And then that's compared to the cost in 2023 after inflation adjustment for basically those same diagnoses. And the concept here is, if you're able to appropriately lower hospital admissions for those conditions where there's evidence to do so, that the physician group would get a share of the overall savings based on the total cost of care, and that savings is either 20%, 50%, or 80%, depending upon how efficient the baseline period was for that group. So it's sort of a complicated model, but it's around lowering admission rates where possible, comparing a baseline to a performance period, and ultimately rewarding high value care.
Right. There is something to be said about clinical gestalt. Certainly, pathways for dealing with chest pain, the heart score, AFib pathways, and so forth. We can use them as guidelines, but look, in a bell-shaped curve, maybe these critical pathways can help in 80 to 85%, but altering physician behavior is really the crux of it, and I think that speaks to where these EPMs are valuable. Steve, would you agree with that?
I think that's true, and I'd expand on it, Rob. So, when we talk about an alternate payment model, it can be of many different things, right? So an alternate payment model could be as simple as a negotiation for a fixed fee per visit from a given payer. In this case, what we're talking about is something much broader in terms of global payments for specific conditions and the care associated with those conditions. Part of this is trying to, I'd say, less alter physician behavior than sort of narrow physician behavior so that we're practicing in similar mechanisms, combined with working with the structures around us to provide the backbone and support that we need to make other decisions. So, for example, you mentioned Maryland is different, and Maryland is different. We've worked under, if you will, an alternative payment model for hospitals for many decades now. And one of the challenges we've run into as that model has advanced is that the incentives or goals for individual clinician groups may not match the hospital incentives or goals. To the degree that a payment mechanism, an alternative payment mechanism, can align those goals, not only are emergency physicians given reasons to think of alternative mechanisms of care, so are our hospitals and so are our community resources. Ideally, the alternative payment mechanism will align us across hospital, across community, and across physicians.
So in comparing this type of model that certainly you started in January of 23 to, say, Kaiser's model, how does that compare?
So, like I mentioned before, there's three different basic approaches. One is to, give a bonus or take away based on an individual quality visit, like did you do X process. Shared savings, which is the program that's in place, and then global capitation, which I think is really the final destination for this, where like in the Kaiser model, they have a fixed amount of money to deliver acute care services to a population, and to do that as efficiently as possible involves not just seeing patients in the emergency department, but doing other things around that can direct patients to the right location at the beginning, making sure things happen efficiently in the emergency department, and make sure that people have good transitions of care after the ED. And that's really the next iteration of this that we're trying to put together, is a global budget model for emergency departments that would do just that. It would really sort of align the incentives with the emergency group as well as the hospital toward really this broader population health goal.
One issue is having the services set up, for example, if we're not going to admit a patient. And that's what Kaiser can effectively do and has done to reduce their expenditures. They have, the ability to pivot quickly away from admissions and do outpatient care and set up telehealth services. And the question is, why can't the bulk of large healthcare systems embrace this type of care that Kaiser has shown to be very beneficial?
What are the goals? What is the mission? What is the funding? And not to be too simplistic about it, but it's that alignment of incentives to say that this alternative destination is important enough to develop it. And none of this happens quickly, right? There's a change in pattern that then is reflected by successful disposition and follow up. Right. I want to know if I discharge someone that they will get followed up, and there's an easy way to get there. In setting up programs like this, there's a tremendous emphasis on that. I want something I can access 24 hours, 7 days a week to make sure it'll happen tomorrow. I need to be able to do it in a mechanism that when it's a 3-day weekend, I have some alternative from Friday to Tuesday. And sort of the emergency medicine mindset of it is important to have things in place regardless of the initial time and day. It's not so straightforward to do, but the answer is yes, if it's important enough.
One of the things that really differentiates any program that we would launch in Maryland and Kaiser is the degree of alignment. And I think Steve got at this, that, wouldn't it be great if you had 3 entities, your insurance division, your physicians, and your hospitals, all of whom had sort of equal incentive to move towards delivering the best product available, so to the patient. That really is what a integrated healthcare model does, because you have a fixed amount of money, you've got the various players in there that ultimately everyone benefits if things happen more efficiently. In traditional fee-for-service, where you've got different parties, that it's broken up in pieces, which really creates a lot of the fragmentation in services and the misalignment. And if the patient does need a rapid follow-up appointment with, let's say, a specialist, an orthopedist, that the orthopedist is not explicitly incentivized or held accountable to actually have that appointment happen, unless you're in an integrated system. So I think that what we need to do is get closer to full integration. Global budgets in Maryland for hospitals is only one piece. Adding global budgets for clinicians on top of that gets us a little closer, but still it's not that full integration, because that's only the clinicians and the hospital itself, and it doesn't apply necessarily to the outpatient environment, where they may not be held accountable for patients to be seen in a timely way. All these models are sort of inching closer to that global capitation, but you're absolutely right, it doesn't get us 100% there.
Yeah, I mean, this is not in any way the carrot or the stick, but physician behavior in admitting, in terms of high admitters, is one aspect to the success of an APM model. And, ability to discharge patients is part of this whole sort of exercise. We need to all work together. I think that's really the message, being unified in terms of reducing expenditures. Steve, at Maryland, I had a question for you. In terms of physicians that are engaged in this APM, do you have to elect in? How is it that ER physicians enter into this? Is that electively, or is it the entire department?
Any of these sort of operations is going to be done by a group. It may be a single hospital group, depending on how it's created, or larger groups. But you point a finger at something very important, which is that so much of what is essential in this comes into the details. Whether, for example, billings are being done exclusively by the group or by the hospital or by a larger consolidated group of emergency physicians. Because these programs tend to be group focused, they're going to be a whole group joining in, not individual clinicians. And I think, I can't speak across Maryland, but I think relatively few of us are independently billing as individuals. So I'm not sure the individual approach is workable.
According to the article, 600 physicians, ED physicians, are part of this APM that was launched in January of 23. How was it that these 600 got selected? Was this an opt-in, opt-out option for, that was presented to emergency department directors throughout Maryland or healthcare systems?
The program was brought together by stakeholders, which included HSCRC, Maryland ASAP, MedCai, Maryland Hospital Association. So that once the program was created, it was then offered as a voluntary program to any physician in the state who wanted to join the program. It is a physician level program. However, to Steve's point, we work in groups within a site. The physicians have to sign what's called a care partner agreement in order to join the program. That 600 physicians did for the 2023 program. But what is being measured is the site level admission for those included clinicians. So again, voluntary program. It's also what's called an advanced alternative payment model, which for the Medicare program, you either can be in MIPS or you can be in AAPM. In an AAPM, you don't have to do a lot of the MIPS reporting. There's no potential downside. The other benefit of the AAPM in 2023, at least, is there's a 3.5% bonus for all Medicare fee-for-service patients for physicians who are participating in the program. So regardless of whatever that potential upside is, the shared savings, you get 3.5%. There's no potential downside risk of MIP. In 24, still trying to decide on what the AAM bonus is going to be. I think the estimate's likely going to be 1.75% of Medicare with no downside for MIPS. And I think that will likely be codified going forward after that, but I think that's still outstanding with a lot of the congressional legislation.
So do high volume hospital systems, the physicians enrolled in these APMs in this program, for example, would certainly benefit more just on volume alone. So the smaller hospitals with lower volumes wouldn't see the economic benefits, I guess, personally to the physicians.
There would be less of a bonus because the bonus itself is correlated with the number of Medicare patients you're seeing, as well as the total cost of those Medicare patients and whatever potential reduction you see. When it comes to a number like the 14-day total cost of care, that ends up being a very large number. So even a relatively low percentage reduction in that number can be a pretty substantial number, even for a small emergency department. I also want to mention there is what's called a 3% hurdle rate. Once you lower costs by 3%, inflation adjusted costs, then you basically get shared savings on the upside. So let's say there's a 5% shared savings on total cost of care for 5,000 Medicare patients at a smaller emergency department. That can still be a substantial number.
Mm-hmm. So the 14-day aspects of care that are part of this program interest me because the downstream care provided after our encounter is really not necessarily all in our control. And so that unification and that teamwork is important, clearly. And how is that all mapped out?
The architecture of the program of what's called the EQIP program in Maryland requires use of a total cost of care as the outcome. When it comes to emergency patients where there's variation in the decision to admit, a lot of the big variable there is going to be whether or not you decide to hospitalize the patient, regardless of what happens in that tail period. So that's really what we found is that, you've got someone with chest pain and you admit them, they're in the hospital for, 2, 3 days, 4 days, versus being lower risk and being discharged and being able to be seen in the outpatient system. That outpatient pathway is going to be much less costly. However, you're absolutely right. For someone that we discharged from the ED, being responsible for up to 14 days of total cost of care is, that was some of the pushback from emergency medicine. How can I be responsible for that? But I think mathematically it works out because of the way that we can control that is through something that we can implement an evidence-based protocol for.
Right. And Steve, at your institution, to employ such a model, would that be feasible in terms of the, say, downtown Baltimore and the indigent population, patients without resources, care, substance abuse, lots of trauma, significant, social determinants of health play a role in this model working clearly?
So I'm not sure there's a question of feasibility as necessity. And I say that from two perspectives. So I'm going to return briefly to a question you asked of Jesse, which is the decision to join the EQIP model. And really the comparison there, no decision is made in isolation. It's not a decision of do we do an alternative payment model or not. The question is, do we do this? Do we do nothing? Do we do MIPS?
Right.
And that made for a fairly simple decision, actually, especially given that the alternative payment model aligns with hospital goals. And I think that gets into your the second question, which is, how do you do this in a downtown setting? How do you do this in any setting? And the answer is we have to be pointing in the same direction. I'm not going to be able to directly influence, in the example, every cardiologist in Baltimore City. However, and this is especially true in Maryland, where we live in an alternative payment model for the hospitals, they're all hearing a similar commentary about trying to keep patients out of the hospital, trying to take care of them at home, trying to direct them toward the most appropriate care in a timely fashion. So that even if I have those direct connections, great. But even if we don't, presumably we are starting to move in the same direction. And obviously all of this will evolve and is continually evolving. But we have to have that coordinated effort. And that is true whether or not we're part of the model or not, simply because of the larger umbrella of reimbursement that we're working under.
Right. So in 2024, Jesse, you had already mentioned about a 1.75% change. You alluded to that. Is the sustainability of this model something that's already in place, or is it, up for discussion? Where do you feel, this is going from a federal or state level overall?
So I really think it depends upon how successful this model is in the first year at lowering costs. And I think that a number of things are going to hinge on that. One is if the groups are able to actually lower costs. Two is participation. And, I don't have the numbers for how many physicians are in the program in 2024. I do know that a lot more groups decided to join compared to 2023. So I think that is one marker that clinicians are deciding to choose this program. The architecture of the program is based on shared savings, which is by definition a time-limited program, which is really the problem with any sort of shared savings model, because you have a baseline, you have a performance period, you can improve on that, and then you can either reset the baseline to a new performance period. You can only do that so many times before you've squeezed out all of the efficiency, and that's been seen time and time again in ACOs, other alternative payment models. So really, I think the final destination for this will be a global budget. Will this serve as a model that could be used by the federal government, by CMS or in other parts of the country? It has a lot of similarities to the ASAP acute unscheduled care model. So, if this is successful, does CMS pick this up? I would say there's a reasonable likelihood of it being offered more nationally. But again, it's time limited, and capitation, global budgets. That's really the only long-term model that's going to really get full alignment.
So in terms of physician behavior, in terms of admitting, Have you seen pressure in any way? Physicians that admit more patients for certain diagnoses in this 500 plus, group of diagnoses.
Yeah, I could comment. That's exactly how we have implemented these programs, and we also have a history of having done this for a few years prior to 2023 in other markets within U.S. Acute Care Solutions very successfully. Our model is one uh, of identifying people who are outliers, and there are tremendous outliers on both the high end and the low end when you look at this. And two, making sure that the data is right. Um, Three is sunshining the data and showing people that they're an outlier, and that has actually a very large effect. Like I like to say that um, you know 95% of physicians think they're above average. So telling a physician that they are not
Right.
above average really often does not compute, and people really sort of may think more carefully about how they're practicing compared to their peers. And then the final area is having those evidence-based protocols be accessible. And a lot of the physicians know about the protocols. Are they using them in the best way possible? That's really the question.
Yeah, and it's certainly admission sometimes is necessary for, again, certain types of patients that don't have the resources or the ability to follow up. So we have to account for that in these models. And again, at larger urban centers with more indigent, population, that certainly is a concern.
Regarding the concept around admission, you're absolutely right. Some people need to be in the hospital. There is a question, though, of who really truly benefits from hospitalization and how we optimize that benefit. There's an underlying question in there of what is the purpose of the hospital. That's a philosophical and rather large question. But we do need to realize it, especially recognize it as a question, especially as we are looking at things like hospital at home and how to operationalize really quite extensive care for people in their homes. The other is a sort of perspective on reducing hospitalization and physician variation. There's sort of two ways to look at what we do when we make efforts. And I want to highlight what Jesse said, that we tend to focus on the person who admits a lot of people, but there's nothing to say that the person who's at the other end and admits the fewest is right. Right? There's a reason some people need to be in the hospital, we think,
right?
And maybe some aren't going in. So one approach is to say I want to shift the whole curve so everybody admits less. The other approach is to say actually I want to get some logic and evidence behind this, so I'm narrowing that curve. Maybe after I've narrowed that and have some better understanding, I'll shift it. Often, though, that first step is just narrowing and trying to see if we're actually practicing in similar ways. And I think we put a lot of effort in that. And that's a lot less threatening as well when we talk about practice and practice variation.
Okay.
Finally, in the economics of all of this, one of the attractions of fee-for-service is it's very simple. You do something, you get paid for it. It's like going to a store. That transactional concept is very simple. The moment we move into other budgetary approaches and models, they become far more complex. And I think one of the underlying streams in our conversation is that the details matter an awful lot. Jesse's example of the time-limited comparison is an incredibly important one, and one that can get lost easily. And the details really get honed as we move along. And that sort of change and honing is very important as we understand better what we're doing it and how to improve what we do.
Right.
Yeah, my only final point here is the importance of involvement of emergency physicians in designing these models is so incredibly important. When these models are designed by economists or folks outside the emergency department, and that apply to the emergency department, there's often a lot of misunderstanding about what we do and why we do it. The early success in some of these programs in Maryland is this was really designed by emergency medicine for emergency medicine. And I think that really has to be the model going forward for success, is that we need to be intimately involved in how these programs are designed and run, because there are a number of potential unintended consequences, you know, that have already occurred in the state of Maryland, for example, with global budgets for hospitals. You know, in terms of not considering how global budgets for hospitals have impacted flow in the emergency department and prioritization of making sure that people are seen in a timely way. We need good physician leadership and understanding of the big picture and stakeholder alignment to make any of this work.
The more we can do to take better care of our patients, but also work on the economic side and try to ease burden on our systems, our hospitals, make it better for everyone. I think that's our common goal. I want to thank you both for a really informative discussion on APMs. Been very helpful. Thank you again.